Hi, is everybody on? Can you hear me? All righty. Well, welcome everybody. I think I'll just wait a minute more for more folks to join, and then we'll go ahead and get started. Thanks for joining us. Thank you for your flexibility. I appreciate you being here. I'm going to send out some notes after this call, and I think it'll just be probably just a list of links. I don't have any new slides. I've been doing several presentations this week just because things have gotten so busy with some of the slides that I shared last week. So I think that had all of the visuals that I wanted to share. As I'm sure everyone is aware, our numbers are going up. And certainly our hospitalizations are going up as well. I had the opportunity to work in the emergency department last night, and we certainly saw, more COVID cases than we have in the last few months. So I think that speaks to the fact that all of our hospitals are telling us that their numbers are going up in terms of admissions and presentations to the emergency department. What I'm going to do, and I'll just go ahead and get started, is to share my screen. And then basically just share some of the websites that I've been looking at, because there's a fair number of different AFLs and other articles that have come along that I think everybody needs to know about. So hopefully you can see this. This should be, can everybody see that? It basically says 1.37 on the left. Hopefully you can. Well, 1.37 is the number that's estimated to be the R effective or the R naught. And whenever the number is above 1, that means that the virus is finding victims at a higher ratio. And whenever it's less than 1, it means that it's basically for every person who's infected, it's not going on to infect one person. So whenever the number is over 1, for every one person that's infected, this virus is finding 1.37 more victims. So that's obviously a statistical measure, but what that means is that the spread is actually increasing and accelerating. It was as high as 1.45, and that number hovers up and down. But as you can see from this slide, it basically is well above 1, has been for really most of July and now going into August. And that's pretty concerning for us. And I basically highlighted the region of our county and the surrounding counties. You can highlight different regions, and basically the story for California is, no matter where you look around the state, people are experiencing an R naught that's greater than 1, meaning that California is basically a hot spot. That should not be news to anyone. This is the CalCat website, by the way. Again, these are all, I'm going to send you links to all of these so you can play around if you want to play around with modeling. But basically, another part of the CalCat website actually shows you the projections for hospitalizations, and you can do it by region. I've done it by county here. You can see Fresno County. So currently, here's where we are. We're just in early August, and they have several different models that they're using. But all the models agree that we are going to have more hospitalizations before the surge ends, and that this will probably take us through August. And in terms of ICU forecasts, that's an even steeper curve, although the numbers are lower. So again, currently we have 160 hospitalizations in all of the general acute care hospitals in our county. And that number may go up to, some models go really high, like in the 300, 400 range. Most models are converging on the 200 to 250 range. And so that's kind of what we can expect through the month of August in terms of the number of hospitalizations. And that's basically about as high as the winter surge was up in the high 200s. So that just goes to show you that, this surge, although we do have more people vaccinated and that's good, this is going to be quite challenging for our healthcare system. And there's some other factors there that I'll talk about later. ICU, again, is going to be busy. It's going to be a busy, probably 4 to 6 weeks is what we're anticipating. And then the number of deaths will climb probably by several hundred, unfortunately, even though this is now a vaccine preventable illness or a vaccine preventable fatality, I guess. Unfortunately, we don't have enough people getting vaccinated soon enough. And so we are expecting the death counts to rise after such a long period when the death counts were very stable. The last CalCat thing that I want to show you is just the overall graph for the number of daily cases. This is something that we're being asked from all corners. The schools want to know, the churches want to know, the businesses want to know, the board of supervisors wants to know, A, is the surge really happening? And B, how long will it last? And this is the best model that we have, is the one that the state provides. And basically you have the same information that we have. There's an optimistic line and a pessimistic line. And even though the pessimistic line seems lower right now, the area under the curve is higher. And so that's basically why it's the pessimistic model. And that will basically top out sometime in late August to September. So again, I know that probably gives a lot of us, it triggers a lot of our PTSD, as it has done for me, that we are going into this again. So please brace yourselves and take care of yourselves and your staff, and just prepare for a very challenging August and early September. We will get through it. I hope that we get through it as unscathed as possible. But unfortunately, that's the reality on the ground. This Delta variant is highly contagious, and it's already finding hundreds of new people every day to infect. And those folks are going to come in seeking care into our acute care facilities and perhaps even our primary care facilities. Any questions about that section before I move on? Okay, great. So sorry to do that. Let me go now to the AFL. So as you know, the state of California puts out these all facility letters, and these all facility letters are basically, they have the weight of law, and they basically are usually technical memos about what's expected at different facilities. So they have actually put out all facility, let me go to the long list. They put out a bunch of all facilities letters in 2021. And then the long list that as of 7/26 was basically, on 7/26, they did the order, which is not listed on this. But then starting here at this blue box, they did an order, or actually an all facilities letter. And all 4 of these came out on August 3rd. And again, I will share links with these. Hopefully you're already getting them, but I will share links to these if you don't get them. But basically, these all facilities letters cover acute care hospitals, skilled nursing facilities, really all the other clinical facilities that are covered in the health officer order, and intermediate care facilities as well. They're all pretty similar, and they all basically outline the technical details of what the health officer order from July 26th is expecting us to comply with. And so I'll just go through some of them. Sorry, I'll go through the acute care hospital one first. And that one's found here. And this is AFL 21-27. And basically this is outlining what hospitals are expected to do. It really is just a rehash of the health officer order letter, which is, verify vaccination in your staff for those staff who are unvaccinated or partially vaccinated. And here's the real juicy part. They have to undergo twice weekly diagnostic screening testing. And for those who are incompletely vaccinated, who work no more than 1 shift per week, you can actually get by with doing just weekly testing. And for those who must undergo weekly testing, they have to get testing done within 48 hours of each shift. And so they basically have to get, a fresh test right before they start working. And then basically, if they don't work in areas where care is provided to patients, they must still undergo weekly testing. So even your admin and your clerical staff who are non-clinical, they still have to get weekly testing done. Really everyone in the facility has to get that done. They talk about antigen tests and molecular or PCR tests. Either of those is acceptable as long as it has an EUA. And then they give you details about the testing that needs to be done. And then down at the bottom, they also mention that for those who are clinical, wherever care is provided to patients or residents, the staff have to have access to respirators, meaning N95 respirators, if they're unvaccinated. So, in our emergency department, that's just a universal standing policy is everyone has to wear an N95 respirator. But just to give you clarity, this is what the AFL tells you to do. So that's for the acute care hospitals. I'm just going to do the one other one, which is the one for skilled nursing facilities. Oh, sorry, my little box is getting in the way. All right, I'll just go back to this and do the skilled nursing facilities this way. For the skilled nursing facilities, they have a similar policy. So basically, you verify vaccination. Here's the different ways that you can verify vaccination. There's different documents that people can present. And then they basically want for healthcare workers, let me make sure this is for skilled nursing facilities. Yeah. So for healthcare workers, they want twice weekly diagnostic screening, if they're unvaccinated or incompletely vaccinated, or if they work less often, they can get by with weekly screening with diagnostic testing. Now, this is a little bit different than another rule that's out there, which is that if your facility has less than 70% of your staff vaccinated and you're a skilled nursing facility, then everyone has to get diagnostic screening, vaccinated or not. So we've got some clarification on that. If that's a question for you or if that's an issue for you, please reach out to us and we can email you. It's like a long explanation from Dr. Siegel about how to harmonize this AFL with the 70% rule for skilled nursing facilities. So if that applies to you and you're confused, then please reach out to us and we will try to help you clarify that, because that took us a little bit of digging as well. I'm not going to belabor it here. What I'll do is I'll add it to the notes. That way you have it on paper, but then reach back out to us if there's any questions that you have about the fact that skilled nursing facilities have two different sets of requirements right now. The way that they explained it is that one of those requirements is going to sunset into the other, but you can see it all on paper. It's a long, nice explanation from CDPH licensing and certification. The other AFLs have to do with primary care clinics and other intermediate care facilities. They basically are the same language, so I'm not going to belabor those, but you can also find those on this list of AFLs. I just Googled CDPH AFLs, and basically you can see them right here. This is like all clinics and then also intermediate care facilities. The language is very much the same. You really should be preparing for August 9th, going into August 23rd. The health officer order goes live on August 9th, and then all facilities have until August 23rd to get into full compliance. So obviously, hopefully all of you are having those meetings about what to do with your vaccine verification of the vaccinated individuals, and then the testing requirements for the non-vaccinated or partially vaccinated individuals. And then if you have any respirator needs or PPE needs, then certainly be working on those. And then email us through the Mohawk system, which is, it's always been around and it's always been live, but it seems to become more important during these surges whenever your supply lines start to get strained. So email us using the Mohawk system, and we can actually try to get some of those supplies for you through the state. Some of you have already done that. I'll include an email for the Mohawk whenever we send out these notes so that we can remind you to use that system. Okay, speaking of supply lines, another thing that you should really have on your radar is these monoclonal antibodies. So basically, we haven't talked about monoclonals in a long time, but we've refurbished our guidance and it's up on our website. And basically new guidance has come out where the FDA is now okaying monoclonal antibodies for post-exposure prophylaxis, and you can give it subcutaneously. So they've taken out the requirement to make it IV, although that is the best way to infuse it. We understand that there's some logistical issues and that you may have to do subcutaneous injections. And they've taken out the requirement to actually be COVID positive. If you have a high-risk patient who's a close contact and you're afraid that they're gonna have a really bad outcome if they end up having positive COVID, you can actually just give them the monoclonal antibody on the day that you discover that they're a close contact. So that's kind of a big change in the policy with monoclonal antibodies. So just be aware of that. Here's the actual FDA language that that substitutes, that basically states that this is okay to do. Again, they're saying prophylaxis, I think everybody knows this, prophylaxis with the monoclonals is not a substitute for vaccination, although it really does give us a new tool in our toolkit to be able to use post-exposure prophylaxis for age 12 and younger, 12 and older, 40 kilograms or more in terms of weight. And it basically will help people from progressing to severe COVID-19, including hospitalization or death. So I'll include this link as well, which is basically the FDA approval for this new indication. Again, remember, bamlanivimab, that's out. Even the combination product with bamlanivimab is out. And this new Regeneron is one of the only other antibodies that's still approved. And that's just because this is still found to be effective against the Delta variant. And so even though Delta variant is raging right now, this monoclonal antibody seems to neutralize that. So that's a really good thing. Remember to have this on your, like I said, have this on your radar, especially if you're working in the hospital setting or overseeing that hospital setting. We also have primary care doctors and even urgent care clinics that are doing this. So really, it behooves all of us to know about this because I think this will actually help keep a lot of people out of the hospital, and whatever we can do to help network and connect people and really build this layer into all the other things that we're doing, including vaccinations, will really help us during this surge. So that's why I just wanted to highlight this. And obviously, I know there's a lot of questions. Read through these two links and then come loop back with us if you have any questions about getting started with this program or acquiring this medication, or if you just need if you need someone else that has done it to just kind of coach you through it. We have several different clinics, hospitals, and doctors that have been doing this for many months. And I'm sure they'd be more than happy to walk you through the logistics of setting up a monoclonal antibody procedure to help your patient population. Okay, I think that's about it. I was gonna go back. I should have probably done this earlier, but this is our actual trends right now, just in terms of what we're seeing. This graph doesn't really do it justice, but this upslope right here in the last few days in the county of Fresno, it is actually, it's real. And so what you're seeing there and what you're reading about is absolutely happening. There's also some hospitalization data that we actually pull from the state. And like I said, this only gets updated once a week. So keep that in mind that whenever it says 50 hospitalized patients, that was several days ago. That number is now 160. This is probably not the best way to display this data. So we're gonna talk to our team to try to get this updated more frequently now that we're in a surge so that everyone can have better information about it. But basically just know that, these hospitalizations are really climbing quite fast. In terms of our vaccinations, we basically have a little bit of a higher demand in the last week because we've been, I think inundated with information on the national level, and we've been actually contributing to the local conversation about the high numbers of cases that we're seeing. And so we are seeing a little bit higher uptake in vaccines, but it's still a long way to go because currently we only have 418,000 residents that are fully vaccinated out of our 1 million residents, and about 75,000 that are partially vaccinated, which doesn't do them a whole lot of good right now, but we're hoping that they get their second dose and that they will be fully vaccinated in the next couple of weeks. We really got to get this number up. We really got to get our adolescents vaccinated because adolescents and young people are really driving this newer surge, and I'm just afraid that that basically whenever schools come back into session, that we are going to have an even increased peak from where we are now in terms of what happens with our case counts. Hospitals around the country are describing really tragic cases of children that are hospitalized. I just read about 2 pediatric fatalities in Tennessee from COVID-related complications. Unfortunately, that's a tragedy that's going to play out with this new surge. We know that it's happening in younger people. We know that even pediatric patients, unfortunately, are not being spared from this Delta wave. And we're just, bracing ourselves and trying to protect them as much as possible, knowing that under age 12 population can't get vaccinated right now. So basically, they're kind of in harm's way. The only real layer of protection that we have to offer right now is social distancing, and when they go back to school, masking. And we're absolutely trying to work with our schools to make sure that both of those are achieved as much as possible. We know that the masking is a point of contention with several of our local school districts, and we're trying to work with them and really explain the trends that we're seeing, because we really feel like masking is the one last layer left to help protect as many kids as possible. And if you're a parent, if you're a member of our communities that is having these conversations, please try to infuse some common sense into the discourse. I can't tell you how important it is to have our medical community, make their voices heard at a time like this. I know that it's contentious and I know that it's scary, but if we don't make our voices heard, then unfortunately other people will craft the narrative in a way that's very counterproductive and very harmful for our communities. So please take that as a plea to really step up and really advocate on behalf of our patients, our communities, our school-age children, and just tell people that what we're seeing in the hospitals is real, and the best way that we can protect people is with vaccines and masking. I can't say that often enough throughout the day, but it seems like we really need to keep saying it in all of the conversations that we have, so that people really understand that these are really the last two tools that we have left against this variant. Lockdowns are really not on the table. No one's gonna have restrictions. I just got off the phone with some of our colleagues in the restaurant industry. They're basically as divided as the rest of society. Some restaurants really want more mandates and more vaccine verifications. Other restaurants really don't. So that's, again, going to be a very contentious kind of policy here locally. And I'm sure if you talk to the gyms and the movie theaters and the malls, you would probably have that same division. So it's really just a very divided time right now, and I understand that. We're trying to do our best just to let people know, based on the facts, based on the science, that we feel like the masking is really important. Universal indoor masking really will help save lives, and vaccinations are obviously very important. And those will, even if they don't prevent breakthrough infections, they will definitely prevent death and keep people out of the ICU. So whatever you can do to help echo those messages and reinforce them, or give us suggestions about how we could be messaging better, we sure would appreciate it. I think those are all the comments that I have today. So that gives us lots of time to ask questions and see what's on other people's minds. So if you have any questions, I'll just go through the chat, or just go ahead and unmute yourselves and fire away. Sounds like Everyday Health is sharing that they're having quite a high positivity rate, probably about 25%, which is really high. I think countywide positivity rate is about 10%, which we thought was high enough, and yours is even higher. Yeah, Lance, I don't know where we saw that ICU status, but I agree with you. We need to do better about messaging what the bed availability is. I just get frustrated when people don't believe that our hospitals are full. Like, they are definitely full, regardless of whether it's full of COVID or full of something else. Every day I go in to our emergency department, I see that, basically we have a lot of folks that are waiting to get care. And now, all the folks that don't have COVID are now having to wait alongside people that do have COVID because of this surge. So I absolutely agree with you that, we could do better with messaging what our bed availability is. But nonetheless, I mean, the healthcare system, I feel like we all work together, not just within this county, but around the whole region. Whenever we can't transfer patients in and out of our hospitals, that really affects the whole region as a whole. And that's basically where things are going, is that, it's really getting harder and harder to move resources around even the whole Central California region. So this is going to strain all of us. Looks like the hospitalization link is up there for you to look at. Thanks, Sim. All right, somebody's asking, will the county be working with schools in developing better safety protocols for COVID? I have a child at Central High, and although masks are required, my child is one of the very few that does it, and it doesn't seem to be enforced. With the new data release, that's concerning. I totally agree. The enforcement needs to be there. The schools, when we talk to them, they've been great partners. We meet with them every week, sometimes twice a week. If Dr. Zweifler's on, he's been a real champion for school safety here in the county, and he's really worked really closely with all of the, oh yeah, Dr. Zweifler is on, with all of the school nursing staff to really go through, like, we've basically built a scenario toolkit, and it's basically many, many pages of, here's, choreographing exactly what you need to do whenever you have a case in the band hall, a case on the sports team, a case in an elementary classroom where there's a stable cohort, a case in a high school classroom where the kids are mixing around with different classmates and in different activities. So all of those are different scenarios that require different approaches. And we've already thought through what that should look like. Basically, it depends on people masking in order for us to keep things open. If people don't mask, then that will basically facilitate the spread of COVID, especially with this highly contagious Delta variant. And unfortunately, that's going to force school closures. That's what I think that some of these school districts don't understand is if they don't enforce the masking, it's just going to take away one layer of protection between them and school closure. And unfortunately, we're trying to give them that information as best as we can, but it's still being drowned out by these other, I would say, frankly, hysterical voices about not having to mask. I don't know if Dr. Zweifler wants to add something.
Well, you covered it really well, Dr. Vohra, as always. The state has come out, CDPH come out very clearly saying that masks are required in schools, but what they also said is that it's up to the school districts to enforce that. So we certainly have weighed in and support 100% the mask requirements, because with our kids, that's the emphasis with the school reopening is to get all kids back in school. So what the state CDPH has done is they've eliminated any physical distancing requirements, so all children can return to schools. They've also established what's called modified quarantine, so that when all children are masked, if there is a case, then kids who are close contacts can also stay in class as long as they remain asymptomatic and get tested. So all of the initiatives from CDPH are with the intent of getting all the kids back in school. But as I said, the actual enforcement of that masking is being left up to the schools. It's frustrating to me because when we think about schools, you're talking about some of the highest risk settings because it's indoors, it's crowded, there are people who are unvaccinated, and if kids are not, then our last line of defense is masks. So, and also if you look at it from the perspective of where we've been with schools, what we've seen is that we started with all virtual learning, then we allowed kids to return with distancing, then with less distancing, and now we're saying no distancing, but to at the same time also say we don't need masks just seems like, why are we doing that, especially in the face of this surge? So yeah, and we're already seeing cases in the schools, and but I think the vast majority of the schools and school districts, and even in the districts where they're allowing what's known as parents to self-certify a mask exemption, I think there's a lot. The general sentiment among all the superintendents is that yes, we should be doing the masking. So I think there's frustration at the schools as well with the way it's been played out.
Certification and how problematic that is? Because I know one of our districts has gone ahead with a resolution that says that that's okay, but that's legally not sound.
Yes. So if you look at the prior guidance around masking and face covering, it did talk about, initially it said, well, you need to have you need to wear a face covering unless you have a medical exemption or you're hearing impaired or it impacts your work, but it is a safety risk at work. But they never, CDPH, they never really said how do you go get that medical exemption. And actually, when Dr. Vohra mentioned that we had developed some school scenarios, and in those school scenarios, we talked about that issue because schools had asked, and we said, well, you need to get a note from a licensed healthcare provider that identifies a diagnosis that's documented in the medical record that is the basis for the medical exemption. So we don't say you have to put it on the note, but we rely on the clinicians. If they're professionals, if you're providing a medical exemption, then the expectation is there is a diagnosis in your medical record that's documented that supports that. And so that's what we've been working with the schools, and we're in the process of revising our school scenarios, but we're basically leaving that same language in there. The state did expand on that a little bit and said, well, it can be either medical, mental health, or disability exemption. But all of those are determinations that in all other settings are done by a licensed healthcare provider. So if you think about things like someone comes to see you for a DMV placard, or they say they're unable to work, so that they can't certify that themselves. It needs to be done by a clinician. And so we don't think that individuals should be practicing medicine without a license. But then that is in effect what is happening with the medical exemption. Not to mention the issue of the stated reason from the school districts that are supporting this is, there's just intense pressure from families, but we see just as intense pressure from families in the other direction, who are concerned and scared about their children going to school when folks aren't masked. And so, in a situation like that, it's like, boy, we should really be erring on the side of health and safety. And that's certainly the position of the Fresno County Department of Public Health.
Thank you so much. A couple of other questions about just the testing of healthcare workers and who pays for it, and whether PCR is okay or antigen is okay. Most of that is in the AFL. They really lay out antigen is okay compared to PCR, although they prefer PCR for obvious reasons, that it's a little bit more accurate. In terms of who pays for it, it really should go back to the insurance for the person who's getting tested. So I think that's who's going to be doing the heavy lifting. It's going to be pretty expensive. It really is. And I think that, eventually, hopefully that will be another reason to get folks vaccinated, is people will see that, it's much more cost effective to get the vaccine. It won't convince everybody, but that's kind of where things are. The AFL doesn't really go into exactly who's responsible for doing the testing, but they just say general acute care hospitals or skilled nursing facilities are responsible for doing the testing and getting it done. So for what it's worth, I can elevate that to get that clarified, but to me, it sounds like, hopefully the person is covered. And then if they are covered, the insurance needs to be paying for their weekly testing. And Dr. Mitchell asks for relevant pediatric studies. Yeah, we will send you the links of the studies that we're looking at whenever we are having these discussions about risks to kids. And really just, the numbers are really surging in that young age population. And so that's kind of what's got us concerned, that we are seeing more and more, younger folks coming in for both the, emergency department visits, as well as being hospitalized. And so across the country, some of the pediatric hospitals are very full. At the same time, they're experiencing, other outbreaks like RSV outbreaks. We haven't even started flu season yet. So we're going to be back to back between the end of this surge and the start of flu season. We're just going to have a very busy fall. And that's, certainly something to be very concerned about. And again, there's now effective vaccines for both COVID and influenza. I know that children are still not eligible. We're hoping that they become eligible soon, but we really can't protect everybody if the people that are eligible get their vaccine. And, one thing that I didn't get to share, I'll share it out later. But basically, we think that all the unvaccinated people, I think there's this general perception that they're all anti-vaccine. That's just not the case. A great majority of people that are Medi-Cal covered are like 66% of them are not vaccinated. And for a lot of that population, it's really just logistical stuff. They can't get time off of work. They can't get childcare covered. They don't have transportation. They may not speak the language in order to get registered in a way that makes sense to them. So there's just a lot of logistical barriers that are keeping people from being vaccinated. Obviously there is a fraction of those individuals who are just adamantly anti-vaccine, but there's many people who, if we just lower the barriers, would actually get vaccinated And that's something that all of us in the medical field need to be aware of, is that, we could probably be doing better with every patient encounter, talking about vaccines, answering people's questions, asking them what their views are, and just really having a motivational interview and really leading them to the right science and the right way to think about side effects and to think about the greater risk of having COVID, and really just spending that time at every clinical encounter. And then at the time of discharge, if you can get your staff to sign them up through the MyTurn app, that would be fantastic. You don't even have to offer vaccines. You just have to get them signed up with an appointment so that you're pointing them in the right direction, and then they have a date and a time to show up. That would actually be quite awesome if we could get all of us to be doing that routinely, and just getting people in the right lane to go get their vaccine, and really just spending that time, because I think that'll be worth it. And that's really what it's going to take. I mean, we're on the media all the time. We're trying to infiltrate social media, blah, blah, blah. I don't think that that's landing, honestly. I think really people need to have credible messages from people that they trust, meaning people of their own identity, in their own community, or a trusted medical practitioner. I think at this point, that's what's going to convince people. I think the media landscape is really, for better or for worse, people are just drowning out things that they don't want to hear anymore, or that they just find confusing. And so I think that it's kind of a lost cause to try to convince people with like large scale campaigns to get vaccinated. Although obviously we're still trying to do what we can. Is there an agreed upon criteria when masking will no longer be required? Now that's a great question. I think in some respects we're going to be masking especially in clinical settings for the time being, and that's just because when this surge ends, hopefully in September is what we're hoping. Then we're going to be coming up with influenza and wintertime respiratory virus season right after that. So to me, it just makes a lot of sense to just mask during those times, whether you're in the clinical setting or even go to the grocery store, et cetera. Beyond that, I think we really need to see the transmission driven way down. And then, people much smarter than me are going to declare herd immunity at some point. And then I think people will really feel comfortable having a broad, consensus that masks may not be required in high risk social settings. But again, it won't be something that we declare at the county level. It'll really require big epidemiology studies to say, okay, we're out of the real danger zone, and that we have enough people, especially the young people that are under age 12, who are now protected either through vaccination or from herd immunity, that we can basically get through with masking. Hopefully it's through vaccination, but at the rate things are going, I think it's not unrealistic to think that we are going to see quite a lot of children getting infected when school comes back in.
Hey, Dr. Vohra, this is Lance Granum. I wanted to ask you a question that I'm getting asked a lot, and that's why is the government not giving any credence at all to acquired immunity? These people want to know why they can't have a test that shows that they're immune and not have to vaccinate with something they feel is only for emergency use authorization. And so I really don't have a great answer for that.
Yeah, that's a great question, Lance. I had a very long discussion with one of my emergency department colleagues yesterday about this very topic, because she basically had COVID, and so she basically wants to know what is her level of neutralizing antibody titers, and that's not really something that you see in the guidance. We're not really testing people for antibody levels before we recommend vaccinations. In fact, there's very fine print that says, if you've had COVID, you can wait 90 days because you're immune for 90 days and we think you'll be protected. But then after that 90 days is done, you really need to go get your vaccine. That's the recommendation. Now, have we seen a lot of people that get reinfected? To be honest, we really haven't. You're not really seeing that. The people that are in high risk settings, the people that are working blue collar jobs at foster farms that are in the line of fire, you know what I mean, are basically not getting reinfected and I'm picking on Foster Farms. I could pick on any number of different industries, but I'm just saying, whenever you see an outbreak going through, it doesn't seem to come through again months later. And so that basically, you know, adds to this, I think, this sense that this is a, you know, for the most part, a one-time infection for people. And then after that, they seem to be immune for the most part. We're not getting a lot of people that are reinfected that get really sick. So for what it's worth, acquired immunity may probably be just as good as vaccine immunity. Now, having said that, is there any paper that I can point to that says you get a, you know, you get a vaccine, you know, exemption because you've had prior COVID infection? I can't find that anywhere. I don't think that that's part of the official CDC recommendations, but it's definitely a fair question, you know, is when are we going to be able to say that, for example, we've had 100,000 infections here in Fresno. Those 100,000 people, you know, are they really now exempt from the vaccine? It doesn't seem like that's what we're recommending, because we just don't have the official, you know, go ahead to do that. But you're asking a very fair question. Is, you know, what do we do with people that have already had the infection? They probably have really good immunity. Now, I don't know if Chris is on, but Chris with the Blood Center has really been at the forefront of some of these antibody studies, because they had a convalescent plasma program that they got started like within weeks of this pandemic. And the convalescent plasma program was really innovative, because what we were asking people, and I don't know if you were listening to those pleas, but basically we were saying to people, if you've had COVID, then please, once you're better, you know, go ahead and donate your plasma, because your antibodies can go save somebody else's life. So that was the convalescent plasma program. Now, we learned a lot about antibody studies because of that program, because it turned out, and Chris can probably make a more accurate summary of this than I can, but basically, out of all the people that gave convalescent plasma, a third of them had really good antibodies that were neutralizing and very useful. A third of them had kind of medium level, and a third of them had like no good antibodies at all. And that's where we said, okay, you know, every survivor doesn't have the same level of antibody protection. And I think that that's the truth. You know, I really do. I think some people have great antibodies and that they're really well protected. Other people, for whatever reason, their immune system just doesn't kick it into high gear. They don't have those antibody levels, or we can't find them at the time that we test them. And so those convalescent plasma studies showed us that not every survivor's serum is the same. And I think that got extrapolated to mean that we really can't trust a natural infection to providing lifelong immunity. You know, I think that that's where that connection got made. Whether that's a valid connection or not, that's up for debate. But I think that's where this came from, is people said, you know what, convalescent plasma isn't 100% great. You know, it really depends on what people's level of neutralizing antibody is. And that's not the same from person to person. So the best thing we can do is just vaccinate everybody. And then that way we've basically guaranteed that they have a good immune response.
For me personally, I have 21 people who work here who are not fully vaccinated. All except for 3 had really bad cases of COVID. So I only have 3 people which are what I would call the highest risk, which have not had COVID,
Right.
will not vaccinate,
Right.
and are very mask reluctant. You'll catch them with their masks off all the time. So non-compliance is an issue, Dr. Vohra. And when you have these people who have had it, it's very difficult.
Well, that's
to
convenient, because it's easier to stick a Q-tip in their nose when they don't have their mask on. So that's actually going to make it convenient when you have to test them twice a week. But no, I hear you. In all sincerity, I hear you. I know how hard it is to be, you know, just being the messenger as you are, and having to enforce these rules that, you know, for the most part make sense, but there's a lot of kind of gray areas and marginal cases where we're just like, well, this is kind of what the rule is right now. And we're hoping that the science or the guidance catches up to cover people that are kind of exceptions. But I totally understand their frustration, you know, as they've already suffered through COVID once, and now they're being asked to do something that they don't want to do, which is to get the vaccine. And my sympathies go out to them. Thank you for sharing that. Yeah, I'll try to track down some of the, Dr. Kokumar, our senior epidemiologist. I've asked her the same question is, can we find some literature about COVID reinfections? And Rick Lembo is adding, COVID reinfections in light of the new variants that are coming out. So suppose you are immune to the Alpha variant. Are you also immune to the Delta variant? That's a fair question as well. Off the top of my head, I don't know any studies that have been done that would answer that specific question. There's just so much that we're learning and so much to still, research on this that it's very humbling. Someone's asking, are the exposure recommendations the same during the Delta time as originally indicated? Yeah, pretty much. We haven't really changed the definition of close contact. We really haven't changed the definition of the isolation period or the quarantine period, but you really have to respect this Delta because this is much more contagious. One of the CDC slide decks said that it's 1,000 times more contagious than the old variants or the original wild type strain. And I think that's probably accurate, whether it's 1,000 times or, a few hundredfold more powerful in terms of spreading itself. So, even though the exposure recommendations haven't changed in terms of close contact definition, it's still, no masked interaction, a non-masked interaction for 15 minutes or more in a closed space. So that's basically still the definition that we use, but you have to understand that Delta is finding victims at a much faster clip than the wild type virus was doing in the same kind of setting. So somebody needs a few doses of Moderna vaccine. All right, so that's a good question. I think what you're asking is people that got the Johnson & Johnson vaccine. These folks are probably having, I don't even want to say buyer's remorse, but there's evidence that has come out that says Johnson & Johnson is not that effective against this Delta variant. And some people have gone really far with that little nugget of evidence. For example, in San Francisco General is now saying, if you got the Johnson & Johnson vaccine, we will actually give you a Pfizer supplemental dose because we just think the immunity that you have from Johnson & Johnson is just not very good. So that's basically kind of rogue right now. That's really not something that even the CDC is saying. Although when you read the literature, San Francisco General is not wrong. But the official guidance is still that if you've had Johnson & Johnson, one dose is fine. I would absolutely not be surprised next week or the week after that if the CDC came out and said, you know what, if you got the Johnson & Johnson dose, then you basically need to get a different vaccine because we're seeing a lot of breakthrough infections in those folks. I will not be surprised whenever that headline comes out. And really, we've been kind of kicking around, should we go forward even ahead of the state or ahead of the CDC and do the same thing that San Francisco General is doing? I think that we're still just kind of waiting to see more evidence that would embolden us a little bit more. But again, it's something to be aware of, especially if you were giving Johnson & Johnson shots. You may be asked to call those patients back. Again, you don't have to do anything today other than read about this. But basically, Johnson & Johnson just seems to not be as good of a protection in terms of the vaccinations as Pfizer and Moderna are in light of this Delta variant. It seems like Johnson & Johnson was really good with the older types of the virus, but with this Delta variant, for whatever reason, the protectivity seems to be as low as 33%, which is really bad. And so that's where people are saying, you know what, let's get these people a supplemental dose of Pfizer, which just raises the question, like, are they doing two doses of Pfizer or just one? From what I've heard, they're doing just one dose of Pfizer up in San Francisco. But again, there's going to be more protocols that come out, and we're not going to do anything that's way outside of the mainstream of guidance. But it is something to know about. And even boosters, I think they're coming. I really think we're going to see a recommendation for boosters in certain populations, like immunocompromised populations, other high-risk populations, et cetera. I really think that there's enough evidence there when you read the primary literature that shows that, again, it's about neutralizing antibody levels, and those neutralizing antibody levels, they're pretty high right after you get the shots. but then they kind of wane, and about 6 months later, they're low enough to where people are like, you know, maybe we should do a booster right about now. You've probably heard that Israel is doing that. There's other voices that are very strongly advocating for that here in the US. And then on the other hand, there's an equity issue where the WHO came out saying that that's really not fair to give some countries 3 doses of a vaccine when other countries haven't even had their first dose for their populations. And so this becomes a global equity issue. And it's not just an equity issue. It really is like, if you don't protect the whole world, then somewhere in the world, you're going to have a pocket of people that are going to create a mutant that then takes over. And so you basically are going to start from square one again. And so it really does behoove all of us to protect the whole world. That's easier said than done, but that's where the WHO came out to say, you know what, before you do third doses for people that are low risk in the US, you should really think about doing first doses for people all around the world that are at super high risk, because frontline workers in places like sub-Saharan Africa don't even have their first dose yet. And you guys are talking about the third dose boosters. Again, I don't know where the CDC is going to land. I think that they have a very hard job trying to, you know, thread this needle, but it is very interesting to read about. And again, not the end, definitely not the last word on where we're going to go with boosters. I think it really will. We're going to see more antibody studies coming out, and we're going to see more kind of breakthrough infection studies come out, which really look at why are people getting breakthrough infections, which vaccine did they get, which allowed this breakthrough infection to happen, what was their antibody level, are there any other explanations for why they got the breakthrough infection, for example, some kind of immunocompromising condition, et cetera. So not all breakthrough infections are the same thing. Obviously, there's a lot of nuance to even those cases, even though they're a small minority of what's going on right now. But I think that's what's going to help us answer who needs to get a booster and when.
Dr. Vohra, I have one more thing. The cluster of breakout cases in San Francisco, the nurses that I'm talking to in infection control groups all go back to during the early release of the vaccines, we were told about how important the cold chain storage was. And when we would see breakouts in groups like this, we should expect that that wasn't properly handled. Do you agree with that?
Yeah, you're right. You know, I mean, every single one of those vials has to be handled in that cold chain, or else, you know, you could have it once you go outside of the range of acceptable range, you basically have to throw that vial out. And you know, those were stories that really grabbed the headlines when vaccines were quite short. They don't grab the headlines as much, but yeah, that's happening all the time. Is the quality control has to be there. And really, it just takes, you know, one mistake to really have, you know, a whole set of people. Usually it's like, you know, what, 10 people per vial at most who end up having, you know, a bad batch, as it were. And then, you know, they've basically gotten kind of a dud vaccine that allows them to get that breakthrough infection. So yeah, you're absolutely right. That could explain some of these breakthrough infections as well. That's harder to track down. I don't know that anyone is even doing that, honestly. Whenever we have our breakthrough infections, and my staff this morning told me we have about 500 here in the county. So we're up to about 500 breakthrough infections, and it's really gone way up in the last week. And basically whole households that were vaccinated are now coming down with this Delta. It's most likely the Delta variant. And so, yeah, you know, as our cases are rising, so are our breakthrough infections. But, you know, in order to do that study, we'd have to go back and say, okay, where did you get your vaccine? What was the date? What was the time? What was the lot that was used? Who was administering it? And really doing like a really good detective story. And I'll just tell you straight up, we don't have the resources to really do that. So unfortunately, while that is a possibility, we hope that that's a small number of cases. And it's probably going to be impossible for us to go back and track down whether that person got, you know, a dud vaccine or not, just because it's logistically very hard for us to do right now. But again, I just want to thank everyone that's doing vaccinations. I know how hard it is to really set up that cold chain, to really dedicate your staff, to get trained and oriented in doing it right. And we know everybody that did this invested a lot of time into getting it right, and we really appreciate that. And I know you guys are doing vaccines every day, some of you, so we appreciate your ongoing efforts. Somebody says, well, 2 people have asked about a mandate for vaccination for healthcare workers. Well, that's a good question. I haven't seen anything official. We've, again, somebody's heard rumblings that CDPH may be issuing a vaccination mandate. Again, I haven't even heard the rumblings, but again, nothing's off the table. We'll certainly, share that information whenever it comes out. I honestly don't know what the status of that is. Whether we could do something like that in the county, that's really interesting. I mean, we're right now just trying to do real basic stuff like encourage masking, encourage vaccine verification and a voluntary compliance with the vaccinations and in all sectors. And beyond that, we'd certainly have to have a lot more discussions if we were going to do anything stronger like a vaccine mandate. But again, we'll definitely keep everybody posted, and I think we'll find out together. I don't know of any other counties that have done it other than San Francisco, and even San Francisco has really made it. Well, I'll have to go back and check. I've really reviewed the Contra Costa guidance, and the Contra Costa guidance was something that we were like about to do here in Fresno County right before the 726 health officer order came out, which basically made it redundant because that was exactly what we were going to do in this county, which is to make the unvaccinated people get testing done in a way to really ramp up our surveillance. But then the state came along and made that happen. So we basically didn't feel like a local order was necessary. And so again, if the state is coming out with a vaccination mandate, then that will basically make a local mandate redundant. But again, I don't have any more information than that to share at this time. All right, good questions. I will definitely try to track down the literature and the articles to answer some of these questions. I really appreciate the time that you've spent and the feedback that you're giving. These are all super important topics, so I appreciate that we can all get together and really share what's on our minds. And we'll continue this discussion next week. And in the meantime, I hope all of you can stay safe and enjoy this relatively cool weather that we're having this week, and hopefully take time out and brace for, like I said, a challenging August, but we will get through it, and we'll get through it together. Let us know what you need, and we'll see you all next week. Thank you so much. Take care.